Welcome back. If you're prepping for the NCLEX, you know valvular heart disease is a must-know topic. Today, we'll break down the 9 essential valvular diseases, what they are, how to spot them, and how to manage them fast and clear. We'll focus on the key features, classic signs, and the why behind each condition, so you're ready for those tricky NCLEX questions. Think of this as your crash course, concise, memorable, and exam-focused. For more study resources and practice questions, check out brispainternational.com. Let's dive in and make you a valvular heart disease pro. Let's dive into the world of heart valve problems. First up, mitral stenosis. To understand mitral stenosis, picture the mitral valve as a door. This door sits between the left atrium and the left ventricle of your heart. It plays a crucial role in regulating blood flow. Now imagine that this door is stuck or has become stiff, barely opening at all. This is essentially what happens in mitral stenosis. Most often, this unfortunate situation is due to a history of rheumatic fever, particularly in earlier years. The rheumatic fever causes inflammation that leads to scarring of the valve leaflets. As a result of the narrowed valve, the left atrium has to work overtime, pumping harder to push blood through the smaller opening. This extra effort leads to pressure buildup in the left atrium, which then backs up into the pulmonary veins and lungs, causing a variety of uncomfortable and potentially serious symptoms. Key signs to watch out for include a low-pitched, rumbling diastolic murmur that is best heard at the apex of the heart. This murmur is often more easily heard with the patient positioned on their left side, bringing the heart closer to the chest wall. You might also observe possible atrial fibrillation on an ECG, reflecting the strain on the atrial tissue. Symptoms often begin subtly with exertional dyspnea or shortness of breath during physical activity. As the condition progresses, it can lead to orthopnea and paroxysmal nocturnal dyspnea, where the patient experiences sudden breathlessness at night, often waking them up gasping for air. These symptoms arise as pulmonary congestion worsens due to the backup of fluid in the lungs. Also, watch for mitral phases, a characteristic sign of rosy or flushed cheeks. In terms of management, diuretics are often prescribed to help manage fluid overload and reduce pulmonary congestion. Beta blockers or calcium channel blockers can be used for rate control, particularly if atrial fibrillation is present. And anticoagulation is crucial for patients with atrial fibrillation to reduce the risk of stroke. For severe cases, interventions like balloon valvuloplasty may be necessary to open up the narrowed valve. In some instances, valve replacement surgery might be the best option. Nursing priorities in caring for these patients include closely monitoring for signs and symptoms of heart failure, careful assessment of fluid status, and providing education on the importance of adhering to a low-sodium diet to manage fluid retention. It's also vital to educate patients about their medications and emphasize the importance of medication adherence for optimal outcomes. So, remember, a history of rheumatic fever combined with a diastolic murmur should immediately make you think of mitral stenosis. Echocardiography remains the gold standard for confirming the diagnosis and assessing the severity of mitral stenosis. Be sure to know these key features of mitral stenosis for the NCLEX. Mitral regurgitation, in essence, is a leaky door within the heart. It's a condition where the mitral valve, which should be tightly sealed, fails to close properly. This means that the mitral valve doesn't close completely, so blood, instead of flowing forward to the body, flows backward into the left atrium during systole when the heart contracts. This backflow increases the workload on the heart. The most common cause is mitral valve prolapse, rheumatic heart disease, a condition resulting from inadequately treated strep throat or post-MI papillary muscle rupture, a serious complication following a heart attack. Classic sign: a high-pitched blowing holosystolic murmur, heard best at the apex of the heart, radiating to the axilla or the armpit area. Symptoms: patients often experience fatigue, dyspnea or shortness of breath, especially during exertion, and atrial fibrillation. An irregular and often rapid heart rhythm. Acute cases can cause sudden pulmonary edema, fluid accumulation in the lungs, and shock. Diagnosis: echocardiogram or cardiac ultrasound shows the regurgitant jet, the backflow of blood, and chamber enlargement, particularly of the left atrium. Management often involves afterload reduction with ACE inhibitors, medications that help the heart pump more easily, diuretics to reduce fluid overload, and surgery, either repair or replacement of the mitral valve for severe or symptomatic cases. Monitor closely for signs of heart failure and assess stroke risk. Chronic cases may be asymptomatic for years, making regular checkups crucial. Watch carefully for any changes in symptoms or condition. Treat any underlying causes contributing to the regurgitation and intervene before irreversible ventricular dysfunction develops. Mitral valve prolapse, MVP, is when the valve leaflets bulge back into the left atrium. Think parachute flaps, often benign and found incidentally but can cause mitral regurgitation in some. Associated with connective tissue disorders like Marfan's. Classic finding mid-systolic click, sometimes followed by a late systolic murmur. Most patients are asymptomatic. Some may have chest pain, palpitations, or anxiety. Management. Reassurance, beta blockers for symptoms, avoid stimulants. Severe cases with regurgitation follow mitral regurgitation protocols. Key MVP is usually harmless. Focus on patient education. Aortic stenosis is a condition characterized by a narrowed, often calcified aortic valve. This critical valve plays a vital role in regulating blood flow. Think of it like a rusty, stiff door, increasingly blocking the flow of blood from the left ventricle, the heart's main pumping chamber, to the rest of the body. This obstruction forces the heart to work harder. The causes are varied, but the most common is age-related calcification, a gradual process that stiffens the valve in older adults. However, in younger patients, a congenital bicuspid valve, a valve with 2 leaflets instead of the normal 3, is often the culprit. This predisposes them to early stenosis. The classic triad of symptoms includes syncope or fainting spells, often brought on by exertion, angina, which is chest pain or discomfort due to reduced blood flow to the heart muscle, and dyspnea or shortness of breath, especially during physical activity. To easily remember these key symptoms, just think of the acronym SAD. On auscultation, you'll hear a harsh crescendo, decrescendo, systolic murmur, best heard at the right upper sternal border. This murmur often radiates to the carotids, the major arteries in the neck. An echocardiogram or echo is the primary diagnostic tool, confirming the diagnosis and assessing the severity of the stenosis. Once noticeable symptoms appear, the prognosis is unfortunately poor without timely valve replacement. The only definitive treatment options are surgical aortic valve replacement or a less invasive procedure called transcatheter aortic valve replacement, often abbreviated as TAVR. It's crucial to avoid nitrates in these patients as they can cause dangerous and precipitous drops in blood pressure, leading to hypotension. Nursing care involves closely monitoring for signs of heart failure, providing education on appropriate activity limits, and diligently watching for any sudden changes in the patient's symptoms. Remember, symptomatic aortic stenosis is a critical condition that requires urgent intervention. Be sure to know the classic triad of symptoms and the characteristic murmur for the NCLEX exam. It's important to understand that there is no truly effective medical therapy to reverse aortic stenosis once symptoms have begun. Valve replacement is the only real solution. Aortic regurgitation means the aortic valve leaks, letting blood flow back into the left ventricle during diastole. Causes: aortic root dilation, bicuspid valve endocarditis, or aortic dissection. Classic findings: wide pulse pressure, water hammer pulse, and a high-pitched decrescendo diastolic murmur at the left sternal border. Symptoms: awareness of heartbeat, dyspnea, angina, and eventually heart failure. Diagnosis: echocardiogram to assess severity and ventricular size. Management: afterload reduction. ACE inhibitors, nifedipine. Monitor with serial echoes and surgery for symptoms or ventricular dysfunction. Acute cases are emergencies, need urgent surgery. Chronic cases may be asymptomatic for years. Key: intervene before irreversible ventricular damage. Watch for signs of heart failure and declining exercise tolerance. Tricuspid stenosis is rare and usually due to rheumatic heart disease, often alongside mitral stenosis. The narrowed tricuspid valve causes right atrial pressure to rise, leading to systemic venous congestion. Signs: mid-diastolic murmur at the lower left sternal border, louder with inspiration, giant waves in jugular veins. Symptoms: peripheral edema, ascites, hepatomegaly, and fatigue. Diagnosis: echo and ECG, right atrial enlargement. Management: diuretics, sodium restriction, and treat coexisting left-sided lesions. Surgery is rare and usually done with other valve repairs. Key: think tricuspid stenosis in patients with rheumatic mitral disease and right-sided congestion. Focus on relieving fluid overload. Tricuspid regurgitation is usually secondary to right ventricular dilation from left-sided heart failure or pulmonary hypertension. Blood leaks back into the right atrium during systole, causing systemic venous congestion. Signs: hollow systolic murmur at the left lower sternal border, louder with inspiration, pulsatile jugular veins, liver congestion, and edema. Diagnosis: echo to assess severity and right heart function. Management: treat underlying cause, diuretics for fluid overload, and surgery only for severe symptomatic cases. Most cases improve with management of left-sided heart failure or pulmonary hypertension. Key: address the root cause, not just the valve. Watch for worsening right-sided heart failure. Pulmonary stenosis is almost always congenital. A narrowed valve blocks blood flow from the right ventricle to the lungs. Classic murmur: systolic crescendo decrescendo at the left upper sternal border, louder with inspiration. Most adults are asymptomatic. Severe cases cause exertional fatigue, dyspnea, and syncope. Diagnosis: echo confirms severity. ECG may show right ventricular hypertrophy. Management: mild cases need only monitoring. Severe cases get balloon valvuloplasty. Surgery is rare. Key: think congenital in adults and intervene if symptoms or high pressure gradient. Know the murmur and intervention for NCLEX. Pulmonary regurgitation is usually a result of prior intervention. For pulmonary stenosis or severe pulmonary hypertension, the valve leaks, causing right ventricular volume overload and eventual dysfunction. Murmur: low-pitched diastolic, best at the left sternal border, louder with inspiration. Most patients are asymptomatic for years. Symptoms mean right ventricular failure is developing. Diagnosis: echo or cardiac MRI to monitor right ventricular size and function. Management: monitor until right ventricular dysfunction or symptoms, then surgical valve replacement. Diuretics for fluid overload. No meds fix the valve. Timing of surgery is crucial. Intervene before irreversible damage. Key: watch for signs of right-sided heart failure and arrhythmias. That's your rapid-fire guide to the 9 key valvular heart diseases for the NCLEX. Focus on the pathophysiology, classic murmurs, and management strategies for each. Repetition and understanding the why will help you ace those application questions. For more practice and study tools, visit brispeinternational.com. Keep working hard. You're on your way to becoming a great nurse. Good luck on your exam, and thanks for studying with me.